By the way, David, did you know that the Taj Mahal was a mausoleum? I don't know what that says about Grant, but anyway. I take great pleasure in introducing our next speaker for many reasons. He's been a friend of mine for a long time. He comes to us from Holland. He is the organizer of the upcoming meeting in Holland. For those of you who just happen to be in The Hague in May, you ought to stop in. It's going to be a wonderful meeting. He is also one of the, I think he was the original founding investigator for the Eurodiale trial, and you've all heard about that, and you'll probably be hearing some more because there are being updates all the time on the Eurodiale trial. All by way of introducing our next speaker, hitting Redial on Eurodiale, a conference call to arms to save legs. Please welcome Nicholas Skopper. Nicholas.
Thank you very much, George. I'm very honored to be here. Beautiful city, beautiful conference with so many people from so many regions. And I was asked to give you an update about the Eurodiale data. Let's start with it. I hope my... Does this one go? Nope. David, I have a problem here. There it goes. Press twice. Okay. Why did we start actually with this multi-center study? Because we asked ourselves the question, what determines the outcome of a diabetic foot ulcer? And if you look at the data, most studies on outcome are single-center studies, or they are trials. And of course, we all know that with randomized controlled clinical trials, you have a highly selected patient population. So, second is that we all had the experience, at least in Europe, that some of the centers were run by surgeons, other centers were run by podiatrists or run by physicians, and they all had the impression we're seeing different populations in different centers, and that of course will also determine outcome. And we thought that maybe healthcare, the former speaker already alluded to it, is an important determinant of outcome of an ulcer. So that's why we started this initiative. And we had the following model. You have a patient with an ulcer, and you have patient characteristics like age, sex, or heart failure. You have leg and foot characteristics like inflow problems with peripheral arterial disease, or you have neuropathy. You have management strategies which differ across countries, and there are different ways to look at it. Early amputation, late amputation, etc. Osteomyelitis, treated conservatively, treated surgically. And of course you have healthcare organization. And then you have your outcomes. And your outcomes, of course, you can have different views on it. You have healthcare consumption. I'm not going to show you these data because the earlier speaker already showed you a lot about economic data, but of course our studies enabled us to do some very nice for economic analysis. You have amputation or non-healing or healing, and you have quality of life. And all these three aspects were addressed in our study. We studied about 1,100 patients from 14 hospitals in 10 European countries. We had a dropout rate of about 11%. And we studied both in and out patients. All patients with a new ulcer were included, be it that they presented at the emergency department, were admitted, or an outpatient clinic. And it was prospective observational study. We had a standardized examination on all these patients, and we had standardized follow-up, maximal 1 year. And all patients were supposed to be treated according to the international guidelines. Well, this produces an administrative nightmare, I can tell you. We were the administrative center, and to cut it short, we had about 1 million answers to the questions that were asked during follow-up, 1 million database. So, and these questions, then they were subdivided, so we had an archive of terabytes, which explains also why we'll still keep analyzing data and producing data, because this is truly a massive amount of data we collected. And actually, we had to change the secretary because she's got overworked. This is the typical patient characteristics. Elderly patients, male, poorly regulated, long-term diabetes. About a third of them have disabling comorbidities like severe heart failure, renal failure, poor vision. And this was, for me at least, shocking. 60% of our patients are not able to do self-care. They're dependent upon others. And we've shown in earlier studies, that actually the quality of life is not only low in a patient with a diabetic foot ulcer, but also the quality of life is low in a patient caring for this patient, for the surroundings. About a quarter was admitted to the hospital, and the majority were treated in primary care before they were referred. The first thing we saw, but that's not so much news, I think, nowadays anymore, is that there was a shift from neuropathic to neuroischemic ulcers. Only about half of them were the purely neuropathic ulcers, which has been published so much about in earlier days, and the other half were either neuroischemic, the blue ones, or purely ischemic, the white ones. So peripheral ischemia, peripheral artery disease, has become a major problem in diabetic foot disease. And that's why you have toe and flow and other initiatives. So these are the characteristics of the foot and ulcer. We just talked about the patient. Neuropathy in not all of them, peripheral artery disease in half of them. The majority, or at least half of them, were infected at presentation. 45% were ulcers deeper than skin, and the majority were relatively small ulcers, between 1 and 5 square centimeters. The second lesson was that the classic plantar forefoot ulcer you find in most publications, at least before in the 90s and 80s, was actually a minority, only 22%. Toe ulcers are the most frequent ulcers. Now, if we talk about healthcare organization, what about referral patterns? Well, about 27% of these patients were late referrals, so there was a major problem there. But that differed so much between centers. Like in London, it was only 6%, while in other countries it was 55%. So this is not a patient problem, it's a doctor problem. The majority of the late referrals were neuroischemic ulcers. So healthcare workers in primary care have problems recognizing a neuroischemic ulcer. They treat it as if it was a neuropathic ulcer. And late referral means larger ulcers. So what about peripheral artery disease? How was it diagnosed and treated in these top centers? Well, first of all, an outcome. We found that the arterial brachial index was raising problems because 1/3 had non-compressible leg arteries. That's a huge number. Doppler pressures were a relatively poor predictor of primary outcome, although an ABI below 0.5 did predict amputation, either minor or major, but there were quite a few amputations in patients with normal ankle brachial index. So if it's low, it's bad news. If it's normal, you don't know anything. In the patients with late referral, the 45% with neuroischemia had not a previous vascular workup, so that's a major problem there. In the patients, and now I'm talking about the centers, all centers supposedly, like ours, to be expert centers, still 54% of the non-healed ulcers after 12 months had not undergone a vascular evaluation. And in 50% of the patients with a very low ABI, a vascular evaluation was not performed. And in 50% of the ischemic leg, no revascularization procedure was performed. So this is truly, at those days, an area of improvement. Offloading. How did we do? We have all kinds of casts in Europe and here, and David knows all about it, and we're going to have a session during this symposium about it. How did we use it? In the classic neuropathic forefoot or midfoot ulcer, only 13% were treated with the golden standard. Well, 14% had alternative casts, so that means that only 1 in 4 of the patients were treated according to protocol. The majority of our patients are not being treated with casts. And if I look, for instance, to the Charcot Registry of William Jeffcoat's initiative and at Jude's in England, I saw that also in England, the majority of the patients with a Charcot are not being treated with plaster. And maybe that's a problem that we have physicians running these patients like I am, because if I would be an orthopedic surgeon, to me this would be unbelievable. A patient with a fracture not being treated with a plaster. A patient with a plantar foot ulcer not being treated with a plaster. Huge variation between countries, 0 in Germany, 71% in the Netherlands. All the patients and women were likely to have no plaster because they refused it. So we went back to all these centers and said, why are you not doing what you're saying you were supposed to do? And we interviewed them and looked at all the individual patient cases. That was the fantastic good news of the Eurodial, because this was such a close group cooperating. People were allowing each other to have a look in the kitchen. They were allowing each other to be completely open to each other. And actually it was not that easy. It was not just clinical inertia. It was reimbursement policies. I think if I'm correct, in Germany there's a major problem with reimbursement. There was lack of qualified staff, like in Spain. But there was also lack of professional acceptance. People said, our orthopedic surgeons or other people doing it because they don't believe in it. And there was clearly also lack of patient acceptance. So this was the input in the system. Now what came out of it? Clinical outcome. Well, it wasn't that bad. 77% of the patients healed without major amputation, although 24% had a minor amputation. 6% died within a year. 5% had a lower leg, and 11% was not healed after a year. And 18% had a minor. I said a wrong number a moment ago, 18%. So if you say healed without any amputation, I think which is the most relevant outcome, it is 64%. So we are able to heal 2/3 of our patients without major problems. Now what determines outcome? Of course, an older patient, male sex, poorer outcome. Bigger ulcers, poorer outcome. Peripheral disease, poorer outcome. Comorbidities, clearly having impact on outcome, like heart failure. Ulcer location. We showed that there is a gradient. Toes do best. Midfoot in between. Hindfoot poorest. And, not strange maybe, probing to bone predicts outcome, and also another analysis, probing to bone is a very good predictor of amputation, in particular minor amputation. Probably it's related to osteomyelitis. Here you see how we split up the patients in patients without infection and without peripheral disease, with peripheral disease but no infection, infection but no peripheral disease, and infection and peripheral disease. And you see in red the major amputations, in yellow the minors. And you see that the major amputation is a rarity in patients without infection and peripheral disease, although still 9% have a minor amputation, probably because they get an infection during follow-up. Patients with peripheral disease, there is an increase in major, there is an increase in minor. Patients with infection, no increase in major amputation, but an increase in minor. And then clearly the poorest group is the patients with infection and peripheral arterial disease. These patients, they do fare very poor. More than 10% major, more than 30% minor. So almost 50% any amputation. So that was one of the major new facts of, not so new, but things which came out of Eurodial. Infection plus peripheral disease is more than double trouble. And why is that? Well, we have shown earlier that if you do mapping of an extremity before you amputate it, and you go from areas well perfused, because the surgeon wants to have the sutures on an area which is well perfused. So that's up here. And then you go all the way down to the toe. And then you give these patients prior to amputation intravenous and antibiotic. And then we measured with APLC, we measured antibiotic levels in bone and tendons and muscle, skin. We found there was a very close correlation between TCPO2 and antibiotic penetration. Even minor decreases in peripheral perfusion resulted in a lower delivery of antibiotics to the tissue. So peripheral arterial disease has a major interaction with delivery of antibiotics, as also shown in another study with another antibiotic. So peripheral arterial disease and infection, we said time is tissue. Train first, then think. Why did these patients fare so poorly? Also partly because these are different patients. They have more frequent non-planters, frequently deep ulcers, larger ulcers, elderly patients, disabling comorbidities. So these are the truly sick patients with infection and peripheral arterial disease. So if you have infection, what does predict poor outcome? And we did a sub-analysis. And we found that if you take peripheral arterial disease, ulcer depth, ulcer size, presence of pain, and male sex, you can develop a risk score which patients fare the poorest. And that was just published in Diabetes Care. You see in blue our optimal model, but then there is a lot of data in there. If you only take 6 items and you put them in the model, you see here the ROC curve of predicting amputation in our population. Of course, this has to be validated in another population. And you see on the right, the orange line, that's the International Working Group classification of severity of infection. So this seems to be a major improvement compared to the International Working Group classification. So here we have a new risk score, and if you simply use these simple terms in an emergency department, you could say, okay, this is a patient with a very high risk of amputation. And this is a discussion I frequently have with surgeons. If you have a tiny ulcer, but it is deep, you have an ABI of 0.7, people say, well, you know, it's not a major problem, isn't it? Well, this patient then has about a 50% chance of losing part of his leg. So, in infection, it's not the infection itself, but it's like Louis Pasteur said, the germ is nothing, it's the terrain in which it grows. That's everything. The patient and the healthcare system. Talk about healthcare system. We looked at center differences. We had here a beautiful example of nature, all these different centers doing all these different things. Let's compare centers. And these centers were willing to do that. And we found huge differences between, on the left, UK, and on the right, another center. Differences between 2% amputation up to 35%. So, is the center on the right doing poorly? You would say so. What are 3 major amputations? But I just told you that it's the patient and the healthcare system which determine so much of the outcome. So what we did was, because we had all these models, we could calculate a severity score for each patient and then add that altogether of the patients per center. So we had a severity score per center, and then compare that with outcome and use minor amputation as an outcome measure. And we found a very close correlation between the center severity score and outcome, which means the red center up there, you can see it. Why did it do so poorly? Because these had elderly patients with peripheral arterial disease, all infected, all deep. While the UK center had younger patients, no peripheral arterial disease, superficial ulcers. So be very careful to use amputation as a quality measure, because this is extremely dangerous. But on the other hand, I have to say there are things we cannot explain. Why is the blue center down there doing so much better than the red center up there? So we went to the different centers, visited them, and we found that the most effective center seemed to have an aggressive approach in diagnostics and invasive treatment with a small, dedicated, multidisciplinary team. Like my next speaker has such a beautiful center and has such beautiful results. But these were based on qualitative data. So this is the team of Alberto, who is going to speak in a few moments. Very dedicated, very aggressive Italian surgeons and internists. Finally, quality of life. We found that 68% of our patients had mobility limitations. Impaired mobility was the most important determinant of quality of life. And now I understand why some of my patients, once they've been treated once in my center, never return, but go to a neighboring center. Because they say, oh, if you go to Schaper, he puts you in plaster. And I can't walk, hardly walk. And then when I'm treated by him, I can't walk at all. Because our treatment even worsens the mobility of the patient. 85% of the patients reported pain and discomfort. So yes, on one hand, it's a painless classic neuropathic ulcer, but these patients do have severe problems with their feet. And at least for me, that was new. I tend to forget that. And that was related to the ulcer, but also to heart failure, mobility, etc. And, maybe not strange, quality of life was an independent predictor of mortality and amputation. So these patients who are already in a poor condition, low quality of life, they have the poorest outcome. So treatment should not only be focused on all these aspects I just discussed, but also on aspect from a patient perspective, mobility, pain, discomfort. So in conclusion, 2/3 of all diabetic foot ulcers can heal without any amputation. Amputation should not be used as a marker of quality of care unless you take a whole bunch of things into account. Peripheral arterial disease has become a major determinant of outcome, and I didn't show you that, but the former speaker also showed you that, of costs. The peripheral arterial disease patients were the most expensive patients. And the combination of peripheral arterial disease and infection is more than double trouble. And time is tissue in these patients. And when you come home, you should ask yourself, if I have a patient tomorrow at my emergency department who has signs of peripheral arterial disease and an affected ulcer, can I guarantee that that patient will have a vascular workup in 48 hours? Can I guarantee that that patient will have a revascularization between 4 or 5 days? If not, you have a problem. And the patient, actually. And more attention to mobility, impairment, and pain. So, going back to the title that was given to me by David and others, we should start doing what we say we are doing, because that was shown by the Eurodial, that all these centers who helped to put together these guidelines how to treat patients, they actually were not doing what they're saying they were doing. And I would like to thank all these people who collaborated with this fantastic initiative. Thank you very much.